I'm Major Joseph. I'm one of the Peds Emergency Medicine Fellows. Today I'll be talking about newborn rashes and birthmarks. As you all know, rashes can be a significant source of parental concern, and maybe one of the reasons parents come to the ED. Most of the newborn rashes are benign and transient. And as PD providers, we should be able to differentiate the benign rashes from the rashes that can be potentially life-threatening and that may need additional workup. Today, the objective of my talk is to discuss the morphology and presentation of benign newborn rashes, life-threatening rashes, birthmarks and hemangiomas, and infantile atopic dermatitis. With that, we'll go to case number 1. We have a 3-day-old female brought in by mom with rash. She has small white to yellow papules and pustules surrounded by erythematous blotchy skin. And this rash is located on face, trunk, and extremities. This is how the rash looks like. What is the most likely diagnosis? Anybody from the interns? Herpes simplex, erythema toxicum neonatorum, congenital candidiasis, non-specific viral exanthem, staph impetigo. Yes, that's correct. Erythema toxicum neonatorum. Erythema toxicum neonatorum is seen in healthy full-term babies, and it appears within 24 to 48 hours after birth. And you see rashes that are like papules and pustules, and it's very erythematous. It has a very erythematous base. Most of the time, it disappears within 5 to 7 days. Parents need appropriate counseling about this rash. When you culture the pustules, the culture is most of the time negative, and you can also see right stain shows eosinophils. This is our next patient. We have a 10-day-old female with a rash. Mother thinks that the rash is due to milk allergy. Baby is fed with formula since birth. No fever, no vomiting or diarrhea. This is how the rash looks like. Based on this image, do you guys know what is the cause of a skin findings? What is it? This is something called miliaria. This is caused by blockage of sweat duct. And this is common in warm climates and humid weather, and when the babies are overdressed or when babies are febrile. Most of the time you see it in forehead, neck, and upper trunk. And there are different types of miliaria. This one is called miliaria crystallina or pseudomia. This one has clear fluid-filled blisters, and this is due to the blockage of very superficial sweat ducts. The next type is called miliaria rubra or prickly heat, and this one involves like sweat ducts in epidermis, and this can be itchy. Next one is miliaria profunda. Miliaria profunda happens when there is leakage of sweat from the blocked sweat ducts into the dermis, and it kind of causes like an inflamed reaction. Next one is miliaria pustulosa, when you have like superimposed bacterial infection. Most of the time, you give like, if it is like milder cases, it's basically the treatment is cooling and avoidance of overdressing. Cooling is like air conditioning or cool compressors. Calming lotion seems to help. In severe cases, you could give topical steroids if there is intense itching. If it is super infected, antibiotics. We have a 4-week-old baby whose adoptive mother tells you about a skin rash present on his face, scalp, auricular area, and diaper area. She says that he had a rash for the past 2 weeks. This is how the rash looks like. If you look at the rash, you see erythematous plaques and greasy scales. That kind of gives you a diagnosis. Seborrheic dermatitis, that's correct. Seborrheic dermatitis. Seborrheic dermatitis we see commonly in the ED babies with seborrheic dermatitis. Most of the time it happens from 3 weeks to 12 months of age. And seborrheic dermatitis in babies has a predilection for the scalp, so that's the reason it's called cradle cat. Etiology is unknown, but sometimes malassezia furfur, the yeast is implicated. Most of the time you give reassurance and you can give like keratolytic shampoos. But sometimes you need like extra treatment. Baby's rash hasn't improved despite that mom was told that it would be self-limited in a couple of weeks. They're back in the ED. What would be the next step of treatment for this baby? Oral terbinafine, clobetasol ointment, low-potency topical steroids and mineral oil, tacrolimus, salicylic acid, and cold touch shampoo. So we talk about low-potency topical steroids and mineral oil. In case it's seborrheic dermatitis is not getting better, you can always use topical steroids and mineral oil. And if it's persistent for a couple of weeks, you can even consider giving antifungal, topical antifungal cream to treat yeast colonization. So next patient we have is a 1-day-old male with widespread rash involving face, trunk, and extremities. And the rash consists of pustules and hyperpigmented macules with discrete scaling. Mother is a healthy 27-year-old African-American woman with no history of medications during or after pregnancy. This is how the rash looks like. If you look at the rash, you can see hyperpigmentation, you can see scaling. So this is transient neonatal pustular melanosis. And it's seen at birth, day number 1. And you see commonly in healthy newborns. Most of the time, it's seen in babies with skin of color, or sometimes in Caucasian mixed too. Initially, it can be either vesicles or pustules and hyperpigmentation. Right stain shows neutrophils, and this is a benign and self-limiting condition. And hyperpigmentation can last up to 3 months.
Oh, that was my question.
Yeah, the pustules and the vesicles disappear in a couple of days, but hyperpigmentation up to 3 months. So next baby. We have a 2-week-old baby with blisters on the leg and diaper area. It's a full-term baby born vaginal delivery. Mother is a healthy 25-year-old. And this baby has this rash. What is it? If you look at the rash, you can see vesicles, clusters of vesicles. Herpes, yes. So this is neonatal HSV. As you all know, neonatal HSV is acquired in utero, intrapartum, or postpartum, caused by HSV1 or HSV2. Most of the time, it's transmitted during intrapartum, 85%. And neonatal HSV can present as 3 main categories. One is the involvement of skin, eyes, and mucous membrane. The other one is CNS involvement. The other one is like disseminated. So the presentation timings, skin, eyes, and mucous membrane, it can happen anywhere between 3 to 20 days. The skin, you can see vesicles. Eyes, you can see excessive lacrimation. Mucous membrane, you can see ulcers. CNS, with CNS presentation can be either with skin findings or without skin findings. And that appears from day number 7, and it can appear up to 35 days. And disseminated, that happens from 3 to 20 days. 70% of untreated skin infection can lead to CNS or disseminated infection. So that's the reason we have to make sure that we don't miss neonatal HSV. So just going over the finding presentation, skin findings. And CNS, it can be either seizures, the baby can present seizures, lethargy, tremors, poor feeding, fever, fluctuations in temperature, hypothermia, full angiofunctional, sepsis or disseminated infection. They can present as respiratory distress, apnea, abdominal distension, ascites, progressive pneumonitis, temperature dysregulation, hepatitis, or thrombocytopenia. And how do you diagnose HSV, neonatal HSV? So you can either do, if you have like the vesicles, you can do the sand smear that we don't do it like routinely. The other thing is CSF culture and blood culture, especially CSF, HSV, PCR. And what do you give for treatment? Acyclovir. So acyclovir is a treatment of choice. For skin infection, the duration of treatment is 14 days. If there is involvement of CNS or disseminated infection, duration of treatment is 21 days. If there is CNS involvement, you have to consider EEG and neuroimaging, because these babies can have complications because of neonatal HSV, and the complications can be seizures, developmental delay, psychomotor retardation, spasticity, blindness, and learning disabilities. One thing to remember is untreated disseminated neonatal HSV has a mortality rate of 80%. Next, I'll go a quick review of newborn bacterial skin infections. This is like a rapid fire session. We have a 10-week-old baby with fragile blisters in the folds of neck, arms, legs, and groin with some perioral crusting. Yes, there's a Staphylococcus aureus skin syndrome caused by exfoliating toxin of Staph aureus, and this affects desmoglein 1. And most of the time it starts as like a sunburn, then it starts peeling. And there's no scarring because it's a very superficial layer of the skin. Babies presents with fever, malaise, and pain. And the treatment is antibiotics. You can consider penicillin resistant penicillin, first or second generation cephalosporin, clindamycin, and if there's MRSA equivalence, you have to consider coverage for MRSA. One of the other things you have to consider in babies is like, because of the peeling, you should make sure the baby doesn't get dehydrated. You have to take good care of the fluid and electrolyte management in these patients. 3-month-old baby boy with recurrent redness and crusting around anal area. Kind of, so yeah, it's like it has a specific name. It's called perianal streptococcal dermatitis. If you have like recurrent infection in that area, which is like tenderness and painful, most of the time it's caused by strep. You see well demarcated erythematous patch, you see tenderness, itching, and discomfort. Treatment is coverage for group A strep. 2-month-old baby with blistering rash on extremities. You can see a flaccid bullae, and when it resolves, you can also see honey-colored crust here. Yes, it's bullous impetigo. Most of the time you can use topical mifepristone. If it is widespread, consider oral antibiotics or IV antibiotics. And dilute bleach bath has shown efficacy if you have like recurrent infections. Any idea what this is? This rash? It looks like something you eat for breakfast. Blueberry muffin, that's correct. So it's a blueberry muffin syndrome. Look at this rash. So you see blue or purple nodules in the skin. And most of the time it indicates extramedullary erythropoiesis. And you see in babies with torch infection. And these babies can have IUGR, jaundice, CNS involvement, deafness, cerebral calcification, microcephaly, chorioretinitis, and seizures. Next patient we have is a 1-day-old baby with multiple papillonodular reddish-brown erythematous lesion and crusts of different sizes. And this is present on the face, trunk, and lower limbs. Mother is a healthy 32 years old female. No history of medications or infections during pregnancy. This is the rash. It's maybe a little difficult. It's like not seen commonly, but just have to be aware of it. This, whenever you see this kind of nodules, this can be like this also is suggestive of blueberry muffin syndrome. You have to consider torch infection, and and if the torch infections are negative, one of the other things you have to consider, you don't want to miss, is neonatal Langerhans histiocytosis. You don't see it routinely, and it's a diagnosis by skin biopsy. But just to be aware. And when you see in skin biopsy, you can see histiocyte aggregates with granuloma, and there is CD1A positive staining. You see something called Birthmarks granules on electron microscopy. If this patient should need like more workup, like CBC, coag, chest X-ray, skin survey, urine osmolality, and torch, serological test for torch, because they always have a tendency to go into disseminated Langerhans cell histiocytosis later. So we need like regular follow-up and multidisciplinary approach. If it is just the involvement of skin, most of the time it resolves by 3 to 6 months. Next we'll go to birthmarks. So you have an 8-day-old baby with a large pink mark on his forehead. Parents are really concerned about it. What is it? Yeah, this is a simple one. This rash can present like this: stroke bite, angel kiss, and this is called nevus simplex or salmon patch. This is one of a common birthmark, and this is because of faint transient capillary malformation. And there's like redness which is accentuated during crying, or when the baby is febrile, or when the baby is straining. And most of the time, this lesion resolves within 1 to 2 years. Next one. Strawberry hemangioma. So nevus vascularis is a little bit more complicated. You see small, closely packed blood vessels. The thing with nevus vascularis is like initially it can be like a faint mark, then it grows as the baby grows, and it can last up to 8 years of age. Then it just goes away. Most of the time it goes away without any treatment. Sometimes you have to use pulse dye laser treatment. You have to refer to the dermatologist. One of the other reasons this baby is pressed into the ER is because of bleeding. So there's always a risk of bleeding. So most of the time, gentle application of pressure in that site kind of helps with the bleeding. So next baby we have is a prenatal baby with a large plaque on the face and the neck. You make a diagnosis of segmental infantile hemangioma. What association of syndrome should you consider in this setting of this birthmark? This baby has like a segmental hemangioma in this area. Something similar to it. Sturge-Weber, most of the time you have port wine stain. It's like staining. But one of the things you have to worry about is like, because it's that area, you have to worry about Sturge-Weber. This one is called something called FACE. I don't know if you've heard about it. There's something called FACE syndrome. FACE syndrome consists of, there is posterior fossa abnormalities and hemangioma in that area, arterial or aortic anomalies, cardiac anomalies, and eye abnormalities. So one of the things you have to worry about FACE syndrome is, if the hemangioma is in the mandibular area, you have to worry about airway compromise. And especially if this baby's presence, if the baby has a hemangioma on the face, and if they're present with stridor and hoarseness, you should consider emergent ENT evaluations in this baby. And one of the things to remember in this baby is you have to remember the infantile hemangioma grow rapidly within 5 to 7 weeks of age. And that's the time they can present to ED with stridor and hoarseness. This is a laryngoscopic finding of the infantile hemangioma. You can see a smaller like infantile hemangioma here, and it's getting bigger and occluding the airway. And these babies need multidisciplinary involvement. They need echocardiography to see if there is any cardiac anomalies, and also because of infantile hemangiomas, they can go into high output cardiac failure. An MRI of head and neck, ophthalmology evaluation, ENT evaluation. These babies are treated with topical timolol in the area of hemangioma. Oral propranolol has found to decrease the size of hemangiomas and steroids. Next baby we have is a 3-month-old baby with a lesion on her face that has been present since birth and has been growing in size. The lesion is not itchy or painful. You can see dull red patch on the face involving the upper eyelid, forehead, temple, and scalp. Somebody told about this. This rash is the port wine stain, and it's a capillary malformation. But when you see the port wine stain in the V1 branch of trigeminal nerve, you have to think about Sturge-Weber's. And these babies are prone to develop glaucoma, and they can also have calcification of leptomeninges, leading to developmental delay and seizures. This is Sturge-Weber, and this is something called tram-track calcification of Sturge-Weber. And one of the main complication that happens with this baby is glaucoma, so they need like urgent ophthalmology evaluation to prevent like any leading to blindness. Treatment is ophthalmology, neuroimaging, and pulse dye laser. Next one, we have a 4-month-old baby with itchy red rash on face. His mother reports the rash waxes and wanes. He is bathed using a normal soap. Sometimes they use a moisturizing lotion if the skin appears dry. They recently introduced peas into his diet and wonder whether this may be contributing to the rash. This is how the rash looks like. You guys know, we see it all the time. This is atopic dermatitis. And this is a chronic pruritic inflammatory skin disease seen in newborn period. Primary symptoms is like cirrhosis and pruritus, and you can have periods of remission and exacerbation. These babies come to ER either with inflammation, exacerbation, sometimes with bacterial infection, and sometimes with viral infection, with HSV, eczema herpeticum. One of the things to remember in babies, eczema, atopic dermatitis is mostly on the face and extensor surfaces, that's elbows and knees. Compared to older children, it's in the flexural areas. Whenever you see punched out lesions in a baby with atopic dermatitis, always consider eczema herpeticum. Treatment goals for atopic dermatitis, you guys all know, anti-inflammatory, liberal moisturization, antipruritic medication, antibiotics if they're super infected. A dilute bleach bath has shown to decrease the colonization in eczema patients, so that is one of the things that's recommended. And one of the other things is like hydroxyzine is one of the antihistamines that can help with itching and also help with sedation in babies. And wet wraps. Wet wrap is like a newly recommended modality of treatment for eczema. Wet wrap is, most of the time, wet wrap is basically a tubular bandage which has moisturizer and topical corticosteroids, and it's applied onto the inflamed areas of eczema. Skincare in atopic dermatitis, as we talked about, is moisturizer, topical steroids. When you prescribe steroids, use like a low potency steroid on face. You can even prescribe medium potency steroid on trunk and extremities. So if you look at the low potency steroids that can be prescribed in pediatrics, the one we always prescribe is hydrocortisone. Medium potency, you can use like triamcinolone. These are the wet wraps. This is like the tubular bandage. This is the baby dressed up in wet wrap. And sometimes you can also, like nowadays, you can also get like the wet wrap suits. You can give like parents like instruction to get those things. So, yeah, take home points. Most of the newborn rashes are transient and benign. Erythema toxicum neonatorum, it appears within 24 to 48 hours and lasts for 5 to 7 days. Malaria is like days to weeks. Seborrheic dermatitis at any age, like during the whole infantile period, you can have it. Transient neonatal pustular melanosis is present day number 1 and it lasts for a few days. The rashes that requires additional workup is neonatal HSV, neonatal Langerhans cell histiocytosis. Whenever you see cluster of vesicles, always suspect neonatal HSV. Remember, untreated neonatal HSV has 80% mortality. And vascular lesion, most of the vascular lesion are isolated, just evolve over time. Give parents like instruction what to expect. Infantile hemangiomas grow rapidly between the ages 5 and 7 weeks. Mandibular hemangioma with spider needs emergent antireferral. And port wine stain in human distribution, think about Sturge-Weber, and think about glaucoma requires urgent ophthalmologic referral. This is my reference.